In rotator cuff injuries, the supraspinatus is the most commonly injured rotator cuff muscle. I always joke around with my students and tell them that if they are in doubt, choose the supraspinatus because that's probably correct. One reason for this is the critical watershed area. This is an avascular area to the supraspinatus tendon, therefore a very common area of rupture. 75% of rotator cuff injuries are going to involve the humeral side or the articular side of the tendon injured, with a tear beginning at the anterior edge of the tendon. When we talk about impingement syndrome, it's typically going to involve the acromion of the tendon injured. Rotator cuff injuries are classified as intrinsic or extrinsic. In intrinsic or intratendinous injuries, we have muscle weakness, and so a tension overload and or muscle fatigue can lead to the humeral head migration. Another intrinsic factor is overuse. If we have an impingement, we're going to have a decreased suprahumeral space due to the thickening and inflammation of the tendon or bursa, putting stress on that muscle. We can also see a degenerative tendinopathy, which is a partial rotator cuff tear that leads to the humeral head migration. We also have extrinsic or extratendinous rotator cuff problems. Primary impingement can be due to the shape and slope of the acromion, which results in rotator cuff mechanical attrition. You can have different shapes, such as a type 1, which is a flattened shape, type 2, which is curved, and type 3 with a hook. Type 3 is going to be a greater incidence of impingement than a type 1 or type 2. In a type 4, you actually have spurs projecting off of the acromion, and this is going to be your highest incident of impingement. In secondary impingement, you will see a glenohumeral microinstability. There's a lower supraspinatus outlet and a greater strain on the tendon. You may see AC joint osteophytes, which increases mechanical compression on the tendon. There may be a coracoacromial ligament thickness that decreases the suprahumeral space, or an os acromiale, which is hypermobility and an anterior projection that leads to that secondary impingement. When we look at the pathogenesis of rotator cuff injuries, understand that there's different injury mechanisms in younger versus older athletes. A first injury sequence occurs because of fatigue, and that fatigue is usually going to be to overuse. When you have fatigue, you have an overload of passive restraints and superior migration of the humeral head into the suprahumeral space. The rotator cuff tendon then receives a compression or a strain. This leads to a decreased rotator cuff force production and a further loss of humeral head control. Eventually, we end up with an increased reliance on the deltoids for force production and a further migration of the humeral head during abduction and flexion movements. This sequence repeated over time leads to secondary impingement. There is also a secondary injury sequence. When we think about deceleration of the arm after ball release during throwing, there are very high tensile forces on the posterior rotator cuff and joint capsule. This leads to a decreased internal rotation of the glenohumeral joint, also called GIRD, G-I-R-D. Scapular dyskinesis occurs as a neuromuscular adaptation to the overhand throw and or in conjunction with GIRD. Remember, scapular dyskinesis is an increased protraction with an anterior tilt of the scapula. So during external rotation, with that increased protraction and anterior tilt, you will have an increased strain on the glenohumeral ligaments. Signs and symptoms of rotator cuff pathology include atrophy of the supraspinous muscle. And the easiest way to check this is to check the supraspinous fossa. The patient will complain of shoulder motion pain and ADL pain. There will be lateral anterior shoulder pain, nocturnal pain with a sleeping impairment. They'll have popping, grinding, and or crepitation sensation in the glenohumeral joint. There will be pain with greater than 90 degrees of shoulder abduction and or flexion, and they will have that painful arc of 60 or 70 degrees to 120 degrees of abduction. There are many different special tests that can be done for the rotator cuff. For the supraspinatus, we can perform an empty can test, which is simply placing the patient in scaption and resisting that movement. For the subscapularis, we can do a lift-off test, which is also a Gerber test. The lift-off test has the hand on the back, and when the person is doing the lift-off test, you want to see if they are just lifting straight off the back. We don't want them rotating their arm off the back. They can also perform a belly press or a belly button test, and that's just showing that they have strength against their stomach. For the infraspinatus and teres minor, a horn blower's test can be performed. And for a rotator cuff tear, we can perform Hawkins-Kennedy. We can have them go through a painful arc, or we can have them do a drop arm test. Diagnosis will be through an MRI or an X-ray. The X-ray obviously to look at maybe some of those shapes of the acromion to see if those are contributing or to see if there's spurs. If a person has chronic rotator cuff pathology, it will result in a subacromion spur formation, potentially cyst formation at the supraspinatus insertion on the greater tuberosity. There can be calcific deposits within the supraspinatus tendon and the humeral head flattening. Treatment will start out as conservative, but eventually it will move to surgical. Tears with greater than 50% of the width of the cuff are repaired directly or with an allograft and with an acromioplasty.